Hello, and welcome to Talks with Docs, a program of the Lancaster County Medical Society. I'm Dr. Dale Michels, a family physician here in Lincoln. And joining me in the studio today is Dr. Steven Krueger, who is a cardiologist. And so with that, we're going to talk about some cardiology issues today. And we thought we would start this afternoon today talking about congestive heart failure. Now, Dr. Krueger, when I trained back in the dark ages, if you had congestive failure, it was kind of a death sentence. Oh my goodness, they've got this. Today, thankfully, not so much.
In the last 20 years, we've made huge progress on the treatment of heart failure. Everything from medical therapy to device therapy. But in the original Framingham information that was published in the mid-'80s, if you had severe heart failure, you were usually dead within 2 years. Now, it's unusual to have somebody die within 2 years, and in fact, it's unusual that we cannot make huge progress in terms of normalizing heart function and prolonging the survival of these patients.
Okay. Well, let's talk a little bit about what is congestive heart failure.
Well, congestive heart failure is not what a lot of people think it is. One of the things that comes up all the time is the patient thinks if they have heart failure, that means their heart is going to stop. There's no question that heart failure puts patients at risk for having their heart stop, but that is not what heart failure is. Heart failure is defined as the inability of the heart to pump enough blood forward to supply the muscles and bones and so on of the body with nutrients, and also allowing for blood to back up from the heart and congest the lungs and back up into the legs and cause swelling and so on. So the heart failure syndrome is one that typically is associated with weakness and fatigue, shortness of breath, ankle swelling, abdominal swelling from fluid, that sort of a syndrome, not suddenly falling over dead without warning.
Yeah, I sometimes tell my patients it's like the sump pump in the basement, but the sump pump isn't working very good and the fluid starts to back up.
That's an excellent analogy. That's exactly right.
So what are some of the causes of heart failure? What are some of the things that we've discovered that can lead people to be at higher risk?
Well, there are about 90 causes of heart failure, but 98% of people fall into one of two primary causes. The first one is coronary artery disease, blocked arteries supplying the heart muscle, thereby either damaging the heart muscle or just decreasing blood flow to the point where the heart doesn't have enough nutrients to squeeze well. It's just like if the blood flow to your leg gets cut off, the first thing that happens is the muscles don't work. You start limping. Well, in the heart, that's what happens. The muscle gets weak, and then the heart starts limping, and it doesn't squeeze the blood out adequately. The heart is an empty muscle, and if it stops squeezing, the blood doesn't move out of it as well. The second cause beyond coronary artery disease is probably a syndrome that probably involves a virus. It's a disease, a direct disease of the heart muscle, and as I said, it's probably either from a virus or else a reaction to the virus. Now, there are other causes, one of which is highly reversible, and that's alcohol. A lot of alcoholics and heavy drinkers will develop a heart muscle problem, and if you withdraw the alcohol, that often gets better.
Yeah, there's some of those that, as I recognize, vitamin deficiency, which also goes along with the alcohol, seems to affect that. People with hypertension for a long period that doesn't get treated, if the heart has to pump so hard against the pressure, some of those people seem to end up with heart failure, maybe because of their coronary artery disease, but sometimes I think maybe just the pressure it has to work against.
Well, the pressure does two things. First of all, the heart has to pump against that pressure. So if the heart is weak or damaged in any other way, it will definitely make it worse. But high blood pressure in itself can cause a heart failure syndrome. The primary mechanism is that the heart gets thicker and stiffer from pumping against that high blood pressure. It's just like if you lift weights, your muscles get bigger. Well, if your heart has to pump against high blood pressure, it gets thicker and bigger, and a thick heart muscle doesn't relax as well. And so you can get what I call the stiff heart syndrome, and the stiff heart is a thick heart that doesn't relax well, and then blood backs up from that. The second mechanism is that the wear and tear of pumping against that high blood pressure over time, eventually the heart starts to dilate and get weaker. And so you can develop the weak heart muscle as well as the stiff heart muscle as a result of high blood pressure.
Do most of the symptoms of heart failure, Dr. Krueger, come on suddenly, or is it kind of a gradual thing that maybe patients ignore a little bit too long or think it's not too bad? Or
well, some of each. Some of it is the straw on the camel's back phenomena. That is, you can lose part of your heart muscle and not really notice it very much, and then you lose a little bit more and then notice it a lot. But oftentimes, people ascribe their decrease in energy and their increased shortness of breath to just getting older. I'm getting old. But in fact, that's not what's happening. It's the weak heart muscle that's causing the issue, and that's a definite phenomenon we see every day. On the other hand, it can come on suddenly if some acute event happens, an acute virus, or more likely, a suddenly blocked artery.
Mm-hmm. Okay. Well, we're talking today with Dr. Steve Krueger, cardiologist from here in Lincoln. We're talking about congestive failure. If you have a specific topic that you'd like to talk to, we encourage you to go to Talks with Docs at lcmsne.org and give us a hint of something that you'd like to talk to. Lincoln has been blessed with a very great medical community, and so we have lots of people out there who can give good information to you who are a part of our public. But today we're talking a little bit more about congestive heart failure, and we're talking about some of the causes. Dr. Krueger, let's talk a little bit about how you diagnose heart failure. Sometimes you and I can look at a patient and say, oh, this patient's in heart failure. There's no question. But oftentimes it takes a few tests to do that. So let's talk a little bit about some of the testing we have to do.
Well, as you said, sometimes you can just look at a patient and tell what the problem, that heart failure is the issue. You don't know the mechanism, but you do know that it's part of the issue. But the main tests that we do, in addition to standard history and physical and EKG and so on, is an echocardiogram. The ultrasound test defines the strength of the heart muscle, the size of the heart muscle. It also allows us to look at the valves of the heart. And valve disease can cause heart failure even if the heart is still squeezing adequately. If the blood is just leaking back and forth because the valves aren't working, that will cause heart failure. And that is easily definable by echocardiography. So that's the number one test. The next group of tests would be directed at trying to define the underlying cause, because the syndrome is there, you know the heart muscle is weak, so now why? And for those things, we do evaluation of the coronary anatomy looking for blocked arteries, and there we might do a coronary angiogram or heart catheterization test, at least a stress test, a stress nuclear exam. Or we might be even doing things like heart biopsies, taking a piece of the heart muscle to look for virus if there's an acute severe viral type problem. But a lot of it comes back to the history. You know, if you've got some 24-year-old healthy female, chances are it's not blocked arteries. On the other hand, if you have a 75-year-old smoker with high blood pressure, high cholesterol, and diabetes, chances are it is blocked arteries, and you may choose the testing based on the underlying clinical substrate.
Yeah, a couple of my patients that have had the so-called viral cardiomyopathy or congestive failure related to that, they're typically younger, and it kind of sneaks up on them. They may have had something they thought was just a simple cold that wouldn't go away. But then they start to get short of breath, and then they come to my office, and from my office they come to your office, and then we start to try and figure out some of these things, typically with the echo and some of the other tests that we can do.
Yeah, one of my more interesting patients in the last few years was a fellow from McCook that presented with I have swelling, came into the doctor with I have swelling, and it turned out he did have some swelling. When we were done, we'd taken 98 pounds of fluid off of his system.
So he had a lot of swelling.
He had a lot of swelling, yeah. 98 pounds is a lot
I'd
of
say
swelling.
It's more common for most of my patients to be 4, 5, 6 pounds. It goes away pretty quickly. It's kind of nice to lose the weight, but it's a heck of a way to do it.
Yeah, you don't want to have to do it this way.
Well, so once we've diagnosed congestive failure, many times it can be done now, I believe, as an outpatient. People don't have to be in the hospital. In fact, we hope they're not sick enough to have to be in the hospital. But once we've diagnosed this, what are some of the treatments we can do? I know you mentioned devices, and I know you have done some work with devices and certain medications. And some of the medicines, when I started training with, that we would say, oh, you can't use that because they're in congestive heart failure. Well, now we use them and with good success. So let's talk a little bit about medicines.
Well, when I was a bouncing baby doctor, the treatment of choice was water pills, Lasix, or other diuretics, and a drug called digoxin, which strengthened the heart muscle. We still use some digoxin, we still use some Lasix, but those are no longer the key approach to heart failure. The key approach to heart failure therapy now is to try to go after the mechanism. And the mechanism by which heart failure gets worse has to do with an imbalance of the sympathetic nervous system, adrenaline, and the parasympathetic nervous system. And so we've been attacking those things. It turns out that our standard therapy now, we learned in the late 1980s, involve a group of drugs called ACE inhibitors. These drugs typically end with the word pril, enalapril, lisinopril, and so on. Those drugs block some of these compensatory mechanisms that are bad for the recovery process. The second group of medicines that we use, I think, were what you were referring to, and that is beta blockers. Again, early on, it was thought beta blockers, these are drugs that typically end in LOL, carvedilol, metoprolol, bisoprolol, and so on. Those drugs were thought to be contraindicated. That is, they made heart failure worse at first. And they do if you throw too much at the patient too fast. You have to start with tiny doses and build up over months for them to work. But they do work great, and they are actually now the key to success. The improvement in survival with a drug such as carvedilol is around 68%. And as you pointed out, we were involved in those initial studies, and we're the ones who showed that. So it's made a huge difference. So those two groups of drugs alone, the ACE inhibitors, and which improve survival 32%, with carvedilol and the other beta blockers, which improve survival 68%, that's 100% improvement in survival from just those two drugs. Then we have other drug therapy that has been shown to be beneficial, what we call aldosterone blockers, spironolactone, and so on. Those drugs will improve survival 15 to 20%, depending upon where the patient comes into the heart failure cascade at. And then, of course, we're always working on new stuff that we think can be beneficial. So the drug therapy are the things that I've mentioned. The second arm of therapy involves trying to do something mechanical to benefit the heart. And we've tried several things through the years, but what we've shown now, what's now been shown to be beneficial is resynchronization therapy. A lot of times the heart has a dysynchronous contraction pattern, kind of a wiggly, wobbly pattern. Heart muscle, when it becomes ill, does not conduct electricity. Normally, when a person has electricity enter their heart, it goes very quickly and the whole heart contracts at once.
Sure.
Like if you touched an electric fence. Okay, in a sick heart muscle, the electricity comes in and then one part contracts, but the other part of the heart hasn't seen the electricity yet, so it's just laying there. Finally, it sees the electricity, so it squeezes, but by that time, the top part is already squeezed out, and so it gives way. And so instead of getting this contraction pattern, you get a dysynchronous pattern. By pacing two sides of the heart simultaneously, you can sync that heart back up and improve that heart function. And we have shown in the companion trial, and others have shown this as well, that improves survival 30–40% more. Now, then there's the issue of preventing sudden death. People who have heart failure die in one of two mechanisms. Number one is the heart gets weaker and weaker and weaker and then they die. We don't see that very often anymore. Between our medical therapy and our mechanical therapy, that's rare. The other way people die with heart failure is they die suddenly. with the implanting of an implantable defibrillator, a machine that shocks the heart when the heart stops, we can prevent 98% of that. So now we've solved the getting weaker part, and we've also solved the falling over dead without warning part pretty well. So that's why the survival has gone up so dramatically in heart failure. This is an area where maybe in medicine we've made more impact than almost any other area in terms of survival and making people live longer. But that's only one of our jobs. I believe my job is to make people live longer, but I also think it's to make people feel better. Now, if I did plastic surgery, I might be to make people look better. But in my job, it's to make people feel better, make them live longer. Do our therapies make people feel better? Well, absolutely they do. The average person's heart improves about 10 points, and that makes a huge difference in how people feel. So we've really made great progress with standard medical therapies and mechanical therapies that have resulted in tremendous improvement.
Okay, well, those are some good points. If you have a physician referral need or a need for a physician referral, please don't hesitate to contact the Lancaster County Medical Society at 402-483-3800, and we can help you arrange to find a family physician or another primary care physician who then, if you need to, will be able to refer you on to a cardiologist like Dr. Krueger or someone else in our Lincoln medical community. So don't hesitate to use the services of the Lancaster County Medical Society. Well, Steve, we talked a little bit about treatment. We've talked a little bit about what the mechanisms are. Let's talk a little bit maybe about some of the things that patients can do before they come to see us or after they've been to see us that sometimes we forget to talk about. I had a patient last week I went to see, and I actually made a house call on him, and his wife said, you know, he's doing much better since I took the salt shaker off the table. So let's talk about some of those things.
Well, that's a great point because there's always an influx of patients right after Easter that had ham for Easter dinner or at other times like that. And there's no question that the treatment of heart failure is largely medical, but the patient has to be involved to optimize our therapy. And there are two things that are critically important in the patient's plan. Number one is salt. You mentioned salt, and that's exactly right. Salt is our enemy. All that salt that people eat, we've got to get back out of them somehow. The second thing is water and fluid. And we all learned from the Reader's Digest Journal of Medicine that you should drink 8 glasses of water a day. And that's fine if you've got kidney stones, but it's not fine when you have heart failure. All that water that people drink, we've got to get back out. And it has a tendency to go in their ankles and their lungs, and so it's a constant fight. Nothing that we do can keep up. People can drink faster than we can get it out of them for the most part. So the best plan is to drink less, eat less salt, and not have to take as much medicine. That's my theory about that. But clearly, some fluid is okay. And what I tell patients for the most part, most patients, is that they should drink just the amount that they need, not extra at all. Don't drink any extra and try to minimize the amount they take in. That varies a little bit depending upon the clinical situation. People who have problem keeping their sodium up, and some people do, then they just can't drink hardly any fluid. You have to be very careful with them. Other people, they can cheat a little bit and get by. So everybody's different on that. But those are definitely things that patients can do to improve the situation.
Yeah, some of my older patients don't necessarily drink because they aren't thirsty. So they might actually need to drink a little bit more, but they shouldn't drink it while they eat their potato chips. They should just have a little bit of water and a little bit more water, and they'll do a little better. What about exercise in patients like this? What's your recommendations for patients who have, and I realize you and I both know that it depends on if they just have a little heart failure versus fairly severe heart failure, which may limit them a great deal. But what about some of the simple recommendations for patients who maybe have had the diagnosis of heart failure and they're now saying, okay, now what can I do? What shouldn't I do?
Yeah, I get asked that question every day. This is an area where the science has been very much lacking until recently. Certain things made sense. It made sense that exercise in moderation would be a good thing to do. But we didn't have any proof about that. In the 1950s, the treatment of heart failure was go to bed for 6 months. And that is clearly wrong. I think there's no question that that is wrong. But you can do too much. That is, people can, with severe heart failure, can exercise too much. So individualizing the exercise prescription for a given patient is one of the things that we do routinely. That is, probably about 4 or 5 years ago, in a series of studies that we did, the HF Action trial organized from Duke University, we showed about a 39% decrease in hospitalization associated with a regular exercise program. So clearly beneficial. Then in what we call the Heart Camp study, which was actually organized by Bunny Prezell, a PhD nurse here in town, we showed that an organized exercise program beat even a home exercise program in terms of lots of things. That being so, we do think that exercise is a reasonable thing to do in moderation, but with people with severe heart failure, it really, you can do too much. So if people have heart failure and they get really exhausted, it's probably too much. One of the things that I believe we have to do for patients is individualize these things, because everybody's different. So if I have a patient that wants to exercise, we can do a test called an MVO2 treadmill, where they walk on a treadmill, breathe in a machine, we measure their oxygen and carbon dioxide. We can establish exactly where they run out of oxygen and what a safe amount of exercise is. And then we have an exercise physiologist, Lori Hess, who writes them an absolute exercise prescription. You can do this, this, and this. Don't do this, this, and this. And it works really well for patients.
Well, and thankfully, starting here in Lincoln a number of years ago and now spread quite a bit across the state, there are a number of cardiac rehab programs. So there are structured programs where people can be monitored, so you can make sure that they aren't overdoing or aren't having any of those irregular rhythms that could be fatal, but they still get some exercise involved on a regular basis. I've read some things recently, and I would value your input on some of the older patients' suggestion that they maybe are wiser to do every other day exercise rather than every day, with the question of whether or not it doesn't allow them to recover maybe just a little bit better. Any thoughts about that?
I've read a little about that, but I wouldn't say that the science on that is definitive at this point in time, but that's a reasonable approach in general.
That sounds like one of those things that's logic but not proven, maybe. Is that the way it is?
Yeah.
Okay. Well, today we've been talking with Dr. Steve Krueger, who is a cardiologist here in Lincoln, Nebraska. We've been talking about congestive heart failure. If you have any topics that you'd like to see on Talks with Docs, don't hesitate to email talkswithdocs@lcmsne.org, and we will try and find the appropriate physicians who can talk about this. Well, Steve, let's talk a little bit about any other thing that you see coming down the road in the heart failure thing that we need to alert patients to begin to think about, to maybe ask their family doctor about whether it's something that they might be able to do or use?
Well, this is actually where I spend a great bulk of my energy, is in new things, experimental trials, trying to find that next great thing for the treatment of heart failure, much like we did with carvedilol and many of the other things we've talked about here today. Right now, there are several things that I'm excited about. We have a couple of drugs, one specifically for treatment of the acute decompensation, the patient that ends up having to come in the hospital because all of a sudden they get in trouble. It's been a difficult group to deal with, and we now have, we're working with an experimental drug that I really have a lot of optimism about. In addition, we have some new mechanical things that we've been working with. We have a pacemaker system called the Optimizer, which I think was a very sexy marketing name for a device, but this paces the heart at an unusual time, which basically discombobulates the cells in such a way that it allows more calcium to flow into the cells, makes the cells stronger. And it does that without burning up more oxygen. It's very, very interesting technology, and we've had really good luck with that device, so that we're working with that. And then we're still trying to reestablish the balance between the adrenaline system and the anti-adrenaline system. And we've got a device that hooks onto the vagus nerve in the side of the neck and causes an outflow to rebalance that system that we feel really good about. We're starting to work with now. So we've got a lot of things in those areas. The other area that I would like to mention that is part of the heart failure syndrome that we don't think of, and is actually a cardiology problem as much as it is a pulmonary problem, and that is sleep apnea. Sleep apnea, it turns out, is a terrible problem for heart failure patients. And we're working with that aggressively in terms of correcting the usual kinds of sleep apnea. But heart failure patients also have a syndrome that is central sleep apnea, where the brain forgets to breathe, forgets to tell the patient to breathe. And what we have now is an experimental device that actually paces the nerve that goes to the diaphragm. So at night when the patient is sleeping and they forget to breathe, the pacemaker just kicks on, tells the diaphragm to breathe, and causes them to breathe. And it is a remarkable device. We're thrilled with what we've seen with that so far. So that could make a big difference in the outcome of patients. When we do not treat sleep apnea and people have it and they have heart failure, they die twice as fast. So this is an area where we should be able to make huge progress.
Well, if you think about it, and as you and I have talked about, and know many of these patients who don't sleep well or breathe well at night when they sleep, it's just like everything else. You can't run a marathon, stop, and run another marathon. You need some rest, and the good Lord kind of put nights in for us to get some rest. Well, if you're not breathing well, your heart's not getting the oxygen. He doesn't really get a chance to rest up as well and be terribly functional the next day.
It's a disaster. I mean, we can't, of all the things that I've done in the last few years in the area of heart failure, I think working on the sleep apnea may be one of the most important.
And there are now some new machines and new equipment for that, so it's not as horrible as when we first started diagnosing it.
No. And what I've found is that patients who do get the right equipment and who do use the right equipment feel remarkably better. So it's not just a matter of living longer. They also feel remarkably better. They have more energy, they can do more during the day, and it helps their heart to recover. It's almost like running upstream when you're treating heart failure with one medication. At the same time, the patient's not getting adequate oxygen all night long while they're sleeping. And we have to fix everything that's broke that we can.
Good. Well, Dr. Krueger, thank you for sharing with us some thoughts about congestive heart failure. It's a problem that's out there. You see it a lot more than I do, but in family medicine, we see a lot of patients. Thankfully, most of them we can do well. So thanks again, Dr. Krueger, for joining us on Talks with Docs.
You're welcome. Thank you.
Thanks again for watching Talks with Docs, a presentation of Lancaster County Medical Society. I'm Dr. Dale Michels, one of the co-hosts, and we look forward to having you join us again as we talk about another medical topic of interest to our patients.